James Howard, Professor of Neurology, Medicine, Allied Health, University of North Carolina at Chapel Hill. So myasthenia is heterogeneous with multiple pathogenic mechanisms, the bulk of which are antibody dependent. We know that FcRn blockers, way back from the 1950s, with Sir Francis Bramble, who identified that was the mechanism by which maternal immunoglobulin crossed the placenta to the fetus and had the initial immune safety net, so to speak, when the child was born. And then the maternal immunoglobulins would dissipate, the child would develop their own immune system. Sally Ward in the late 1990s, 2000s, and I can't give you the exact date, recognized that the FcRn, the neonatal Fc receptor, was ubiquitous, and it served as a salvage pathway for IgG. And so IgG gets recirculated over and over and over and has a very extended half-life. And then it was believed that if we could block this mechanism, we would be able to clear antibody, pathogenic antibody primarily, but also good antibody transiently. And we found, or they found, the community found that by blocking this neonatal Fc receptor, and immunoglobulin is pinocytosed into the cell, binds with high specificity to the Fc receptor, and then is transported back to the cell surface, re-released into the vascular space. And if you block it, that free-floating immunoglobulin gets shunted to a lysosome where it's destroyed. And this was the basis of the development of Fc receptor blockers to clear circulating immunoglobulin antibody. Clearly, an AChR positive antibody, MuSK antibody, it has its use. And the difference with complement is that the AChR antibody, because it's IgG1, IgG3, activates the complement cascade. MuSK antibody is IgG4 and only minimally so or does not activate the complement cascade. And that's why complement is only used in AChR positive patients. But FcR receptor blockers can be used with any immunoglobulin, IgG molecule or antibody. We know that the majority of patients are AChR positive, depending upon who you read 80, 85%. Somewhere between 5, 10% have antibody to muscle-specific kinase, MuSK. LRP4, depending upon who you read, 1 to 5%. I think it's on the low end of that. And then there's this pool of patients that by commercial assay have no antibody. And there are a number of potential reasons. One is that there is no antibody that we've identified yet. There could be antibody at such low level it's not detectable by the assay. It could be that the antibody has binding characteristics that the current assays, as crude as they are, don't pick it up. We know that those who do not have antibody have a circulating factor. We base this on the plasma exchange data that we have, where we've therapeutically apheresed these individuals and they get tremendously better very rapidly. So there's some circulating factor. And statistically, in all, knowing what we know about MG, it's going to be an antibody. And so the decision was made that this is a population that, while small in overall number, is a population that is begging for therapy. And our current healthcare systems here in the States and elsewhere only support or pay for that which you have approvals for. And that drove this study. This study was started to be designed several years ago by a colleague of mine, Jeff Guptill, and at the time we couldn't shop it around. It was too expensive. And of late, this sort of fell in our laps that, yes, we want to do this study. And so the then big question came, if you're seronegative, could it be something other than myasthenia? And we clearly see that. Other diseases, oculopharyngeal muscular dystrophy, have similar weakness, have droopy eyelids. Disorders of the mitochondria, mitochondrial myopathies, similar. So there's high rates of misdiagnosis. There are congenital forms of the disease. And so to enroll this study, we said we need to set the bar high. And so we created an adjudication committee that critically reviewed all of the patient's data, their clinical response to therapy, because these other disorders are not going to respond to things like plasma exchange or cell set mycophenolate mofetil or azathioprine, things of this sort. We looked at their physiology very critically to be clear that it demonstrated abnormalities of neuromuscular transmission. And then a go, no go decision was made to allow them to be included in the study. The MuSK population, if they had the MuSK antibody, clearly allowed to enter the study because we had a defined antibody. But those who were triple negative went through this process. And we created this cohort that, for the most part, was uniform. There were a few things that were different in the population. I don't think it had any impact on the outcome. And then treated them. And the design followed similar designs of efgartigimod trials. Intravenous, administered weekly ×4, and then we invoked an observation period to see what happened. We said that would be 5 weeks. And then we rolled them over into open label. And there we decided we would treat you with 2 cycles of therapy with a fixed interval of 4 weeks in between. So 4 weeks on, 4 weeks off, 4 weeks on. And then they would roll over into an extended open label portion where the treatment interval was based on the patient's response. And what we demonstrated is that, yes, the study demonstrated clear-cut efficacy that was statistically significant. We saw differences in the rapidity of efficacy in those who were triple negative and LRP4 negative had a slower onset of effect. And so we started to see significant improvement in the second cycle of treatment. So as they rolled over into their first open label, which then continued to get better the longer we treated them. And so the population of a whole was positive at the start, and then the subgroups were positive at the start for MuSK, for LRP4, and then became for the triple negative as we gave them their second course, telling us that if you only treat them with 1 cycle and they don't get that much better, don't abandon them. Keep them in mind, let's treat them again. And then we'll see the effect. And if we treat them a 3rd time, that effect is even better. So we've answered a question that antibody plays a role regardless of the subtype that we're seeing, that even those who have no detectable antibody by commercial assays, they would benefit from this as well, and that antibody is driving much of the myasthenia that we see. The commercial assays are very crude and don't really reflect disease activity at the moment. And so we could be below their detectable levels. It could be that the kind of antibody, even though it's an antibody to the neuromuscular junction, its binding characteristics could be such that our assay doesn't pick it up. We have what are called cell-based assays, which were developed by Angela Vincent in Oxford, in London many years ago, that pick up individuals who by standard assay are negative, but do have evidence of antibody. So there are a number of factors why we can't find circulating antibody in these folks, but it doesn't mean they don't have antibody. It's going to be huge to the MG community. These people struggle and our payers deny everything left and right. And it's a very underserved population. They represent small numbers in the community, but an academic center like mine, they're almost the majority of patients that we see because no one wants to deal with them. They don't know how to deal with them, so they send them to the university. And so this will be huge.